Okay. Good evening, everyone. Good evening, audience from Dubai, UAE, and Middle East. It's my pleasure and honor to be chairing this session today. It's a series of headache webinar that we started as a collaboration between Emmons and MCO. Today, we are hosted by Lily for this event. Neuro series is a series that we started in 2020 to update our neurologists, our general practitioners, and nurses, and the people in the field of neurology, in the field of medicine, about the update in neurology, mainly in the headache management in this webinar. My name is Dr. Suhail Al-Rukin. I'm the president of Emirates Neurology Society and a consultant neurologist at Rashid Hospital. I would like to introduce our two speakers tonight, Dr. Abu Bakr Al-Madini, who's a close friend of mine. We have been together with Abu Bakr for more than almost 15 years. Abu Bakr is a senior neurology consultant, and he is working at Rashid Hospital and at United Medical Center. Dr. Muna Thakur is a well-known neurologist in Dubai. Currently, she's working at the Zahra Hospital as a consultant neurology, and she has been also working long time at Rashid Hospital. Dr. Muna is a specialist in headache management, acute stroke, and other neurology disease. She has been having an experience more than 20 years in the field of neurology. Our topic today will be a focus in two areas. First one is update in anti-CGRP management, mainly with the new treatment that we are having for stroke prevention and stroke acute migraine prevention and migraine management. Dr. Abu Bakr has been running the headache clinic in the DHA for the last 3 years, seeing different type of headache, mainly migraine and cluster tension headache and secondary headache. Then we will have Dr. Muna Thakur, who will speak about interest topic case challenge with atypical headache presentation and thunderclap headache. We should finish around 2:30. You will be more than welcome to share your question and comments through the Q&A button and at the end. In the lower part of this video conference. I would like to thank Lily for their support for this event and MCO for organizing this meeting. I would like to invite Dr. Abu Bakr Al-Madini to start his first session, anti-CGRP in migraine management. Welcome, Dr. Abu Bakr.
Thank you for your nice introduction, Dr. Suhail. So let's start the meeting. Good evening, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. My objective in this talk would be presenting two cases and the circumstances around the treatment for the two cases. It's a delicate cases which shows how important it is to treat with state-of-art treatment. Okay, thank you very much. So as I said, I will be presenting two cases today, and we'll talk about circumstances around it. Okay, so we have our disclosure is the meeting will be sponsored by Lily, as it was mentioned by Dr. Suhail. So the first case, 44-year-old right-handed female. She's working as a teacher, as a profession. She's married and has 3 children, and she is divorced. Being divorced tells us many things in a world of headache. She's been having headache for the last 20 years. She's been married before being divorced for the last 25 years. Headache is very classical for migraine headache. It is worse with light and noise. It is unilateral, located in the frontal, temporal, and occipital area. It is worse as the day goes by, and it is associated with daily photophobia. Actually, the photophobia bothers her most. She's having daily photophobia, and it is bothering her activities of daily living at her work, at her home. She cannot do her work. She cannot do many things, many social activities due to her headache. Okay. In the course of her disease, she's tried multiple prophylactic medications. So when the headache is debilitating, we start usually prophylactic medications. And she started first time with amitriptyline, and she started up to 75 milligram HS. Her weight is around 70. And usually with amitriptyline, we go with 1 milligram per kg as maximum. And she tried the maximum dose. It helped her initially, though she stopped it due to drowsiness and weight gain. Weight gain is a nightmare for women. So don't tell them any medicine which causes weight gain and you give it to them. They will not like you at all. So I switched, or someone switched a dose to topiramate. She used it for approximately 6 months, but she had very debilitating symptoms. And she came to me telling me, doctor, I forgot my headache because I'm having a lot of memory problem. So therefore we stopped it. She went to propranolol, which is a beta blocker, and she had absolutely no benefit with it. And we tried 2 courses of botulinum toxin injection every 3 months. The headache was helpful initially. Then on next time when I tried her on it, she stopped. The headache was not helping her, and she said, "No, I don't want botulinum toxin anymore," because she was using 31 injection and she didn't like the pricks. And at that point, because the headache was debilitating, I said, "Okay, let's give it a second thinking." We did an MRI with MRV of the brain, which was normal. We did a series of blood tests, which were all normal. She had history of spontaneous abortion, and therefore I thought about antiphospholipid syndrome, and all these thrombophilia screen were done, which were normal. We ended up doing lumbar puncture at the end, and it did not show anything to suggest any secondary causes of headache. So he was still labeled with migraine headache. And she said, doctor, I need help here. Okay. So we had option with many other medications. We knew that at that time, that was approximately 1.5 or 2 years ago. The galcanezumab was introduced back then. Aimovig was there. There are another options as well, such as botulinum toxin injection, along with oral prophylaxis. You can do physiotherapy or along with trigger point release, sphenopalatine ganglion block or others. So all these options were raised to her. Okay, so just to let you know, sphenopalatine ganglion block is mainly designed to inject the sphenopalatine ganglion, which has an afferent coming from the trigeminal nerve and efferent for sphenopalatine or the glossopharyngeal nerve. So we know that pain is usually caused by trigeminal nerve. So you directly inject it with the lidocaine, and usually is very efficient in acute treatment of migraine. If you use it frequently, like 3 times a week for 3 weeks, then it may help. But if you imagine you tell the patient, I need to give you injection 3 times a week for 3 weeks, in total of 9 to 12 sessions, injections, what would they tell you? It's usually not practical for a working patient. But this option was raised to her, but she declined. Okay. Trigger point release was tried in many cases which were helpful. You usually use the landmark where we use it for botulinum toxin. So 31 injection, and you hit where you have the headache. So the area where the patient is having headache, you hit it with lidocaine, and it's sometimes very helpful in acute migraine. This was raised to her. She said, "Doctor, I tried botulinum toxin, and it was very painful to prick me." So she wasn't welcoming this idea. Okay, so she agreed to start galcanezumab. We started her on 240 milligram loading dose. Her MIDAS is migraine inventory disability score, which was 21, which means it's severe. The higher numbers you have, the more severe the case it is. The headache days were 15 days before starting the galcanezumab, and she had headache severity approximately 8 out of 10. She had component of medication overuse. She was using Panadol, paracetamol, morphine, more or less on daily basis. I started her on galcanezumab. That was my first experience, so I wanted to see her right away in less than 1 month. And I saw her in 1 month. The first month, she told me, "Doctor, thank you very much." Her headache improved, in fact, after a few days from onset or start of galcanezumab injection. Her headache used to be 15 days per month. It became more or less 4 days per month. And her headache severity was reduced by at least 30 to 40%. It was 8 out of 10. It became 5 out of 10. So that's from the first month. The effect was obvious. So I saw her again after 3 months. Her MIDAS scores was approximately reduced by at least 50%. So it was 21, it became 12. Her headache days were reduced, so it became 9 days overall totally in the last 3 months compared to 15 days. So it's approximately less by more than 40%. And the severity were reduced from 8 to 5. That's after 3%. So she was happy with it. She thanked me for it, and she said, "Let's continue with it." We gave the other shot after 3 months, and I saw her again after 3 months. The benefit were continuous. In fact, her headache days were reduced. MIDAS was reduced as well, and even the severity were reduced. So the headache days per month became 2 per month, so 6 overall for the last 3 months compared to 9 and compared to 15 before starting her the galcanezumab. So usually when we start prophylactic medication, we give an option of 6-month course. Then we tell them whether they want to continue or stop. The patient choose to stop galcanezumab and see how it would happen, what would happen when stopping. Okay, she stopped galcanezumab. She continued with Endural, I believe. Oh, I'm sorry. She continued with topiramate, low dose, 25 milligram HS for 3 months. Sorry. So the question is here for me, what would you do? Would you stop this Emgality? Would you continue medication for another 6 months? Or would you stop Emgality and start prophylaxis? Or would you choose other options? So on her, we stopped the medication. And we started her on prophylaxis, oral prophylaxis. Next slide, please. But after 3 months after stopping Emgality, I saw her again. She started again having 15 headache days in the last 3 months. Her headache severity was 9 out of 10, and MIDAS score became 19, which is, as per the number, is very severe. And she said, "Doctor, let's start the injection again." And I started her on it with the loading dose, 240 milligram. And I saw her right after 1 month. So the headache will reduce on average, if you consider 15 days in the last 3 months, so that means 5 days per month. The headache reduced by at least more than 50%. And the severity will reduce by more than 40% as well. So that's from the first month of starting Emgality again, she started improving. So that's a remarkable effect. I believe the loading dose plays a big role in having an abrupt effect within few days. So it's not in the slide. I saw her. She's still on it. She's been on it for the last 15 months, and she's very happy with it. She has more or less no side effects. She is divorced. She doesn't want to be pregnant. She's not worried about this part. So that's the case on the 44-year-old lady who improved dramatically with Emgality injection, and she's continuing it for the last 1.5 years. So a little bit about the Emgality, a little fact about it. So we know now that Emgality has effect within few days, and the studies showed the same effect as well. So galcanezumab showed significant reduction in migraine headache days, starting from day one. In fact, starting sometime in day 2 or day 3 or day 4, but some in most dramatic history, we start seeing effect in day 1 as well. And the effect is persisting here, even after 3 months. And that showed it for most of my patients in headache clinic, in DHA and other private clinic as well. So even the mean headache days were reduced compared to placebo. And the effect, most importantly, persists even after a few months. Next slide, please. So as I mentioned here, the effect of the headache days reduced even from day 1, and the effect is persisting in the 2nd month and the 3rd month. And it's the same effect of reduction of migraine headache days. Second, next slide, please. So those are on chronic migraine. So we're talking about chronic. So the second case is a very well-known guy, 65-year-old right-handed CEO. He's a very renowned CEO in a bank. He's been having intermittent episodic headache, but he's never been on any treatment. He cannot afford having medications. He has classical migraine headache, which is unilateral, throbbing, lasts from 4 to, on extreme cases, 72 hours. Sometimes he gets status migrainosis, which lasts for 10 to 12 days, which is very debilitating and causes absence from his work. And he cannot afford being absent as a banker and a CEO. But he was tolerating this. He was taking Brufen, immigrant from Germany, and was coping with it. But recently, in the last few months, he started having increasing headache. He required many hospital visits, approximately 2 hospital visits per month. He goes to emergency. Imagine someone who has migraine goes to emergency. People with migraine, you know that they have phonophobia, photophobia. In emergency, you have all the exposures to exacerbate the migraine headache. So you're not doing good thing for them to send them to emergency. And on average, he was having 7 headache days per month. That was before the treatment. Next slide, please. Just to tell you what he has in the past medical history, he has asthma, he has AV block, and he has mild cognitive symptoms, which is likely due to his anxiety rather than organic cognitive symptoms. He cannot afford having daily medication, and he clearly expressed that to me. I said, doctor, I don't want any injection. Give me something to clear my headache. Don't give me medicine which I need to take every day. And I scored his MEDA score. It was 24, which is severe, as we mentioned. So MEDA scores, in summary, for those who doesn't know it, we calculate the days the patient have absence from work, days from that patient is working, but it's not working efficiently. Days that patient are not working at home at all, or days that the patient are working at home, but they're not working efficiently, and days that affects the social activities. So that we calculate all these days and accumulate them and put them in total. So 24, it means that he had 24 ineffective days at work and at home and social. His neurological examination was normal and his CT, brain, and MRI was normal. Next slide. This patient knows me very well. He told me, doctor, you know to play poker? He said, yeah, somewhat. He said, you know what joker is? He said, yes. So he said, don't give me the small plays. Give me the joker right away. I said, okay, maybe insurance will not accept it. What would you do? He said, I'm ready to pay if the insurance is accepting. So I chose my joker, which is Emgality, and I started him with the loading dose. And that's what happened to him. Next slide. So imagine MIDA score of 24, and with the headache, approximately 7 headache days per month. From first month, again, less headache days, 4 headache days per month. And all of them were moderate severity. And most importantly, no hospital visits. Imagine he was going to emergency twice per month. And from first month, no hospital visits. And he's not using over-the-counter medication anymore. So the headache was tolerable and he was able to conduct meetings at a bank. And I saw him after 3 months. I was seeing him every month, but after 3 months, the score of the MIDA score, if you remember the MIDA score from the previous slides, was 24. See, it's reduced more than 50% reduction. But he had only 1 hospital visit due to severe headache. It was in the weekend, fortunately for him. And the severity score of the headache was on average 4 compared to 7 and 9 before starting Emgality. And the effect continued. No hospital visit. I've been seeing him only for 6 months, so I don't have longer data for him. The effect continued with no hospital visits, less severe headaches, with an average severity was 3 out of 10 compared to 7 and 8 before Emgality, and only 1 headache day per month compared to 7 headache days per month. So that's more than 60, 70, 80% headache day reduction. So that's a marvelous and extravaganza response compared to before starting the medication. And he was right. He told me at the end, doctor, you really choose a joker. I said, thank you. I'm fortunate that I started on him. Next slide, please. So little facts about Emgality, galcanezumab. So we know that for fact, and I know this not only based on papers, I know that for fact based on the population of patients whom I started on medications. The effect is rapid. It starts at 1 week, and I believe the effect starts very quickly because of the loading dose. And it showed in the first and the second trial. The effect persists even for a longer time, and it's same effectiveness of reduction of headache days for 6 months compared to the placebo. Next slide, please. Here, this is a very important slide. If there's anything you need to know, this is the number you need to know and to tell your patient. So how effective is reducing headache days for Emgality? So you try the 50% reduction of the headache days, 75%, or 100%. So in 60% of patients, they have more than 50% headache days reduction. So if they have 10 days, they will have 5 days. So that's 50% headache reduction. 40% of them, or more than 39% of them, had more than 75% headache day reduction. That's a significant number. And most importantly, 16% of them had no headaches. No headaches. So that means at least 1 in 10 have no headache for a few months. So that's a significant number. And Evolve 2 shows pretty much more or less same data. So imagine you tell the patient, I'm giving you medicine, and you have a chance in 1 in 10 or 1 in 7 that you may not have headache at all. So that's a remarkable study. So we usually say when you have headache, don't ask for headache, no headache, 0 headaches. But with this, based on this study, you can tell that you may have 0 headaches, at least 1 in 7 or 1 in 10 or 1 in 15 chance. So that's a remarkable number you need to remember. Next slide, please. Okay, so how many percent would have 50% reduction of MIDA score? More than 80% or 70% in other study had more than 50% reduction of the MIDA score. That's a big number. So that, in fact, shows in my patient, it's more than 50%. So the MIDA score were in 20s became down to 10s. So that's a remarkable number, which is reflected in real life study as well. So that's a very important number you need to remember. The reduction of headache days and reduction of MIDA score. So you can comfortably tell the patient these number based on study which is mentioned and the real life trial based on numbers of patients we've seen. And I think most of people who tried Emgality for their patient are sharing same opinion as me. Next slide, please. So the reduction of headache days from baseline was maintained over time, even for longer time. So we had the 6-month data, we have 12 months data now, and the headache reduction was maintained, and that showed for my patient as well. The second patient, the patient, the teacher, she's been having Emgality for the last 15 months now, and her headache reduction is maintained. And even the MIDAS and the headache days were reduced significantly compared to before starting the Emgality. And we know it's a very safe medicine. Next slide, please. Okay, how safe is the medicine? How do you know how safe the medicine? So we know that if the patients continue with the medicine, that means that the patient is not having side effects and it's safe for them. So 82 to 88% of the patient completed 6 months of episodic migraine studies without discontinuing the medicine. And 95% of them completed the 3 months chronic migraine headache study without stopping the medicine. Less than 2% discontinued the medicine due to adverse effects, and less than 0.5% discontinued due to injection site pain or reaction. On my patient, I had approximately more than 60 or 70 patients with Emgality. None of them stopped it due to injection site reaction. Over 80% were reporting or experiencing minor side effects, and none of them had constipation as a side effect. None of my patients had constipation as a side effect, to my knowledge, because I see those injection patients every month, and I ask my nurse to ask them specifically about the side effects, and none of them had constipation as a side effect. So that's a remarkable medicine. I mean, we call it a miracle medicine, which we need to put for patients in first line in some occasions. Next slide, please. Okay, so the idea of starting the loading dose is to reach the steady state concentration. You can reach steady state concentration very soon with the loading dose within a day. And therefore, people get the loading dose of 240. So that's a benefit compared to other monoclonal antibody drugs. The effect may last for longer time or may start longer time. For Emgality or galcanezumab, the effect would last or would start usually within days in best case scenario. So therefore, probably the idea of having loading dose of 240 injection to begin with. Next slide, please. Okay, so in summary, the Emgality is effective in episodic and chronic migraine, including in treatment-resistant patients. It has statistically significant, meaningful, higher reduction versus reduction of headache days versus placebo. It has significant higher response rate compared to placebo in across patient population. It has also significant reduction in frequency of migraine headache days with associated potentially disabling symptoms of migraine. Okay, so this is a very good data in both episodic and chronic migraine. It has early and sustained effect. The effect may start as early as 1 day. And I've seen some case, and I give few patients, that's off the topic though, and two patients with cluster headache, the effect was within hours, few hours, the headache was reduced. The effect is maintained up to 1 year in best case scenario. So early and maintained effect up to 1 year, and few cases of mine up to 15 months as per real life study. So that's a remarkable study and remarkable medicine. So this is very tolerable medicine across, and it's tolerable across the population, and it showed it to me, and it showed it in real life as well. It's easy to use. It doesn't require any titration. Most of my patients, they use it alone at home. Why? And the COVID period, people don't like to come at hospital and get the injection. They tell me right away, doctor, teach me how I do it, and I do it at home. So most of the patients are using it at home. That's the benefit of it. So in summary, it's a very good medicine. The number you need to remember, 1 in 7 or 1 in 5, 1 in 10 chance that you may have no headache for a few months, for longer time. But more than 50%, they have more than 50% reduction of headache days. So that's a remarkable medicine that you may use it as a joker for resistant patient, or you can start it in naive patients as well. Next slide, please. I believe we end up your slides, and thank you very much for your patience. And
thank you, Abu Bakr.
Hand the phone to Dr. Sale.
Assalamu alaikum. Thank you, Dr. Abu Bakr. A great presentation, nice review. As you said, having a new choices of treatment for the chronic migraine, it's very important. For years, we didn't have any new things in this field. Having CGRP as a new novel treatment that can manage and treat chronic migraine is something we were looking for. As you know, that CGRP has been under study since mid of 1990s, and finally we were able, by the help of the researcher, to get this medicine. We have many patients that getting this medicine through our different hospital, governmental and private. I'm so glad that we were able to be the first country in the Middle East to get this medicine and to provide it to our patient who's suffering from migraine. Dr. Abubakar went through different etiologies, spoke about the benefit of having a new novel medication. There's many questions, Dr. Abubakar, that will be addressed after our second speaker, who will be Dr. Mona Takur.